Well, what a great morning. It was really exciting and fun to listen to our speakers here, and I'm privileged to get to continue that on this afternoon, and hopefully some of what I'll talk about will reflect back on what we've already heard today. This is my first time in Alabama. It's been really a nice visit so far. We had a really great evening last night, and I've really appreciated the hospitality. I want to thank Joy for inviting me. And I'm excited to be here, and particularly excited to be in Montgomery during National Black History Month. So I'm hoping to get out to see the Dexter King Memorial Church this afternoon and get a little bit of history lesson. So I'm excited about that. So what does somebody from Oregon know about trying to help with health care delivery in Alabama?
Great question.
I know a lot about healthcare professionals and how to help train healthcare professionals to do their job more effectively and more efficiently. So I'm hopeful that that is something that I can offer here to help in all your efforts as you move forward in this new initiative for the state. Before I get started into the talk, I want to make sure that I acknowledge one thing, and that's that a lot of the literature and the science and research that's been done around health literacy and what I'll call clear communications has been done amongst physicians and in medical school training settings. And a fair amount in nursing settings as well, and less research and less writing has been done amongst other healthcare professions. So I want to make sure that I'm clear that when I'm talking about clear communications for healthcare professionals, I'm talking about all of us. I'm talking about every single person who has anything to do with delivery of healthcare to anybody. So if it sounds like I'm focusing in on physicians, partly that's because that's who I know the best, but it's also because a lot of the literature comes out of that area. But I believe strongly that all of the principles that we're talking about here apply to every single one of us, including people who are working in public health settings who may not actually interface directly with patients, clients, and consumers. So I wanted to make sure that no one is feeling left out here. But I wanted to start with a quote. Communication works for those who work at it. I love this quote. It's so simple, but it really encapsulates a lot of the problem that I'm going to try to outlay for us here today. And that is that for decades now, we haven't been working at it. We've been operating under assumptions that we're doing a good job. And in fact, when we go out and do research on this and we ask healthcare professionals about their communication skills, they generally say that they're doing a great job and that they're great communicators. And what I'm going to outline for us here in the next little bit is that science doesn't bear that out. We're clearly not communicating well, but we think we are. So we've got a lot of work to do, and if we work at it, I'm confident that we can really improve the delivery of care. Here's kind of an overview of where I'm going to go with the next 40 minutes or so. I want to talk a little bit about how I believe that the health literacy issue in the United States is really a healthcare professions issue, not so much a patient, quotes, problem, but really a healthcare problem. And I want to talk about where we are at as a country in terms of preparedness of our healthcare professionals, where we're at currently that will help us know where we need to go next. I'll talk a bit about just some best practices. We've heard some of them mentioned in passing this morning. I'm going to just dive into them a little bit more just to give us a little more flavor for some of the things that are quite simple but people are not doing in their practices currently. And then I'll leave off with some information about how you as a state and how the rest of the country might approach trying to improve training for healthcare professionals. So I'm going to start with this graphic that comes from a colleague of ours, Ruth Parker, which I think really captures the problem for us. On the left-hand side of the picture, You see the yellow arrow representing patients' skills and abilities, and all the things that we've been talking about this morning. And what we've come to discover here in the last 15, 20 years is that those skills and abilities are surprisingly low for a huge segment of the population. And that's what we're calling health literacy, right? Or lack thereof. What we've really only recently become tuned into is the other side of this picture, which is the giant red arrow representing the complexity of health information and the demands that the healthcare system places on our patients on a continuous basis. And if you notice how those arrows are weighted, the healthcare profession side is much bigger. And what that really is trying to show us is that we are constantly overwhelming the average patient with the type of communication and information that we're presenting them with, continuously bombarding them with more than they can typically handle. What I want us to do as a country is to figure out how to shrink that red arrow, how to lower the barriers to understanding, right? A lot of what we've been talking about today and a lot of the research and the work that's been done, that's been amazing, excellent work over the last 10, 15, 20 years in this field, has focused on the yellow side of things and helping patients become better consumers of information, how to get information better and how to use it better and be smarter as patients. And that's really important. But we're still left with a situation where no matter what kind of setting you go and look at, patients come away feeling like they're operating in a foreign language and not knowing what to do. And I think that it's incumbent upon us to lower the barriers to that. So I want to talk about this thing called clear communication, which I've kind of labeled here on the red arrow there. If health literacy is a patient characteristic, let's say, then clear communication or lack of clear communication is a healthcare profession's characteristic, right? And that's what we're going to talk about now. So what is clear communication? A definition, it's actually really poorly defined and really rarely written about what it actually is. And this is an old definition. We were talking about Pfizer as an old funder of this kind of research last night. This definition goes back to 2004. You can't really find a good definition in the literature that's any newer than that. But clear communication is written or spoken communication which helps patients understand and act on healthcare information. Simple as that. Unfortunately, most of what's available out there doesn't fit this definition, doesn't fit this, right? Doesn't qualify. Clear communication is plain language. It's simple, clear, jargon-free language. Presented in its simplest form. It's not complex. It's the need to know information that a person needs to know to act on to achieve a goal in the immediate let's say that day. What do you need to do? It's written materials that are accessible to most people who are going to encounter them. So what do we think is what's the average grade level reading skills in the United States? Anybody know? I heard 6th. 8th, I heard 8th. Okay, 8th. If I had a prize, I'd give it to you. 8th grade is average across the country. I'm not sure exactly what it is in Alabama, but in the United States, average is 8th grade, right? So here's average, right? So that means 50% of adults are reading at a level below that, and 50% are reading at a level above that. And if you want your written materials to be accessible to the majority of people who might encounter them, you need to write them at a level that's down here so you can capture that whole group, right? So written materials need to be written at a 5th to 6th grade reading level, and that's really not that easy to do. And it's even harder to find materials that have already been produced. Clear communication also anticipates and expects that there are going to be misunderstandings. It doesn't assume that people understand. It assumes that they will have difficulty coping with the information, and it plans for that and prepares for it. And then it checks to see how well information has been delivered. And finally, it does all this in a shame-free manner that says all this stuff is difficult and everybody's at risk all the time, and you shouldn't feel bad if you don't understand it, and we're here to help. So we've seen some statistics for the state, and this one is slightly different. This is representing adults in Alabama who have below basic literacy skills. And these are estimates based on national data that estimate approximately 500,000 adults in this state are functionally illiterate or clearly have skills that are far below those necessary to cope with health-related information on a continual basis. These two colored bars here. The one in the center of the screen, the tall bar, this is to represent the population, the adult population in this state. So by U.S. Census Bureau statistics, there's approximately 3.7 million adults in the state of Alabama. And the small bar represents the healthcare workforce in the state. So about 170,000 individuals there. So now when we're thinking about initiatives to try to tip that balance, those two arrows, right, and try to shrink the red one or grow the yellow one, where do we put the money, where do we put the energy? Clearly we need to put a lot of energy into patients and improving their ability to be consumers of information, and that's incredibly important. But if you're a funder and you want to look for a place to put your money, you might look at the healthcare professionals themselves as a place where you can get the biggest bang for your buck, because look at how much smaller that population is. First of all, there's a lot fewer of them, so they're easier to access. You know where they are, but you also know some things about that population. You know a lot about what their prior education has been, and you have some influence over their continuing education or the education that they will receive through their schools. So through their accrediting bodies and other places, we can really influence what happens to those people, and we can really change that population much easier than we can change the skill sets of the broader patient population. So where are we at in preparedness for dealing with health literacy issues in the U.S.? We're not doing that great. As it's already been mentioned, that really seminal report that came from the Institute of Medicine back in 2004 heavily focused on patient skills. But buried way back on page 161 in that book are some important comments that talk about how ill-prepared the healthcare workforce is, and how we should be trying to put more efforts into educating the workforce in this area and to understand what health literacy is and figure out the skills to cope with it. Now, fast forward a little bit from 2004, there have been a number of studies that have gone around and looked at to see, well, what are people, how well are people trained? And really, the bottom line of it is that the healthcare workforce in the United States right now is really ill-prepared to cope with health literacy issues. Healthcare professionals across the board, across professions, lack a general awareness about what health literacy even is, certainly lack the knowledge to be able to deliver care that's clear and and understandable. They lack skills, and they lack attitudes that can promote clear communication. So it's clear that our training programs have not produced a workforce that is yet ready to deal with this. We know that people in the healthcare professions have a very difficult time recognizing low health literacy when it's in front of them. So a number of studies now have confirmed this, that we just can't tell by looking. And that's something that we've heard earlier today. You can't tell who has low health literacy and who has high health literacy by looking at them or by the usual types of interactions that you have in a clinical environment. So a usual office visit for me, I'm a family doc. If I have a 20-minute office visit with a patient, the way information flows back and forth during an office visit for me does not give me what I need to know whether that person understood or not. And in fact, if the studies that have been done on this have done things like follow physicians and other healthcare professionals throughout their day, and then at the end of the day say, here's the patients that you saw today. Which of these people has high health literacy and which has low health literacy. And every time this has been studied, the providers really could not tell at all. They just got it wrong, either one way or the other. So we can't tell. The other thing that's really important is that as people working with patients, healthcare professionals consistently and constantly vastly overestimate the skills of their patients. So when we study this, we go out and we ask, what percentage of your patients that you work with has low health literacy? The estimates are usually 50% below what actually is going on. All right. So we've got a blind spot here, right? Now, for these reasons and some others that I won't talk about, when we go out and study, what are people actually doing? People working in the field. What kind of tactics are you using in your practice to help improve communication, to be clear, and to improve outcomes through better communication? It turns out that people just are not doing the things that we would consider to be best practices. They're just not part of most people's repertoire. And this is, again, across professions, everywhere that it's been looked at. When we ask our learners to say, you have a patient here who has low health literacy, how confident are you in your ability to communicate with them and to provide good care to them? They really tell us they have almost no confidence in their skills. So you can see I'm painting this picture here of a real deficit model, right, for us. We tend to think of health literacy as a deficit model for patients, but we have our own really important deficits that we need to own and bring to bear here, I think. When we do trainings, like I'll call this a training, this is really kind of a conference, but in a way this is a training. This is an awareness-raising activity that we're engaged in here today. When we do go out and do trainings and we ask people who participated in these trainings, what did you know about health literacy before the training, and how do you feel about it afterwards, and what do you know about it afterwards? Consistently, across the board, people say, I thought I knew what I was getting into. I thought I knew what this topic was about. I really did not know what I was getting into. I had no idea, and I really overestimated my understanding of it. And I'll give you a personal example. When I do a lot of talks in Oregon and other places about health literacy, like all of our other speakers do, and whenever someone at our hospital asks me to do one, and they tell of course I always say yes, but they'll put up some posters in the hospital when we have speakers for the noon conference thing, and they'll put a poster up saying, come to a talk at noon on health literacy. And I know for sure, because I work in the environment every day, that all my colleagues walk past that every day and they look at it, and I know that in the back of their mind they go, health literacy, I don't need to do that one. I know that stuff. I'm good at this. I already know what it's about, and I already know, and I don't need it. Okay, but I'm a scientist who studies this stuff, and I know for sure that they do need it. They just don't know it. So they don't know what they don't know, right? And that's incredibly frustrating to me, because the people who need it the most don't recognize their deficit. They don't recognize the fact that they don't know anything about it. So how do we get people to the table? This is always the question. And I was sitting behind the pillar before, but I couldn't see how many physicians were in the room. So there's a few physicians here. So thank you for being here. Physicians are terrible about showing up to health literacy trainings, right? Because we think we know it all. And actually in studies, when you ask physicians, are you a good communicator? Well, most of them say yes anyway. But the ones who rate themselves the highest in communication skills get the worst ratings from their patients and from the nurses that they work with. It's an amazing paradox. So there's a giant challenge here, though, that you'll have to face in the state, which is how are you going to get your physicians on board and get them in the door? I think it's fair to say that when they do show up, all of this information resonates very well, and they love it, and they'll get excited about it. But getting them to show up is going to be the challenge, and I think you probably have to carry a big stick. So I want to just give a little sampling of some of these best practices that are not being practiced currently, but that we know should be. And just to give you a kind of a deeper look at a few of them, I'm just going to talk to you about five of them here. And these are ones that we've heard a little bit about before. By way of a little bit of background, myself and a couple of colleagues a few years ago set out to try to identify the competencies that healthcare professionals ought to be learning as part of their training. And as part of that project, we identified a list of best practices from a really extensive literature review. We kind of read everything that was out there. And we made a giant list of the things that people in the field were recommending that we do to try to be better communicators as healthcare professionals. And then we did this consensus project with a whole bunch of health professions educators from across the country. The consensus project ended up with a list of 32 best practices of things that we could be doing to improve communication for people with lower literacy skills. Well, 32. It was just way too big. Too many things. There's no way, as an educator, that I could take this to the deans of our schools and say, you know, I know you're busy, and I know the students are busy, but here's 32 more things you need to be teaching. Right? It just wouldn't happen. So we took that list, and more recently we've done a second consensus project where we've gathered a group of health literacy experts, 25 experts from across the country. We've asked them to try to rank these 32 items to try to get a sense of like which ones are really the high yield stuff and which are the ones that if you really don't have the resources, you kind of leave till later. But to try to find out what is that sort of the cream of the crop best practice thing. So I'm going to show you what I'll call the top 5 best practices from that project. And so I've got them listed here. Now, it's a little misleading to have them listed as 1, 2, 3, 4, 5 because the way that we did this process, you can't actually compare. One doesn't really mean that number 1 is actually better than number 2 or that 2 is better than 3. I just have them listed that way for kind of clarity's sake. Just think of these as kind of a basket of items, and each one, they're all kind of equally weighted, but these are the top 5 out of those 32, okay? So if that's clear enough, sorry. It's kind of vague. But what's new? So let me go through them one at a time. So here they are. So I'll go through them one at a time, but we've heard a little bit about universal precautions. We're going to hear more about that in the afternoon with Dr. Betancourt. So I'll spend a little bit of time talking about that now. Plain language, we've heard some of that, and I'm going to give some examples here in a moment. Limiting information, we've also heard that mentioned. Eliciting questions in a patient-centered manner, that's going to be a new one that I'll tell you about. And then the use of the teach-back technique, which we've heard mentioned as well. So let's go through them one at a time. So universal precautions approach. How many in the room are familiar with the universal precautions in health literacy settings? This is not a... Okay, so let me cover this for just a second. So the idea is this. Turns out, right, that low health literacy is really the norm, not the exception, right? We're just realizing this. What we haven't talked about is the fact that patients go to great lengths to not show you that they don't understand something, right? And there's a whole complex psychology behind that we don't have time to talk about today. But suffice to say that it's humiliating to appear to be, quotes, ignorant or, quotes, stupid, which is what these are patient words that they say. So when patients don't understand something, what do? Silence. They nod. Oh, they lie. They lie. Okay.
Yeah, preserve their dignity.
To preserve their dignity, they go to great lengths to make it appear as if they understand. All right, they smile, they nod, they say thank you, and they say, no, I don't have any questions when you ask. okay? But we know very well, and I'll tell you about it a little bit in a second, that they don't understand. The other thing I just told you about was that we as healthcare professionals can't tell when someone's understanding and is not understanding. And then it was mentioned earlier that Dr. Davis here developed one of the most widely used screening tool for health literacy skills. We can't really use those in clinical settings, so we can't really try to figure out who's got high skills and who doesn't. It turns out that it's not going to be very useful to us in a clinical setting. Really important for research, not so useful in a clinical setting. So our solution is to say, look, every single one of us, regardless of how much education we've had, is at risk for not understanding, right? When Dr. Davis was going through her own health issues, we couldn't count on her to be able to track information. It was complicated. There was a lot of stress involved. And with her incredible academic background, health information was difficult to manage, right? If you're sick, you're scared, or you're hurt, nothing makes sense. So we got to use a universal precautions approach, use plainest, simplest communication with all patients, regardless of what they look, sound like, what we know about their background, and we'll never be wrong. And if a person really wants more information, they're going to seek it after that. Okay, but we got to get away from this mindset that some of my patients want sort of this kind of information, and some of my patients really need this kind of information. Everybody really prefers the simplest version. Best practice number 2, using plain language or non-jargon language. Well, it turns out this is really hard to do. And even studies that looked at people who know a lot about health literacy, with doctors specifically who know a lot about health literacy and who know that their patients have low health literacy, still use jargon terms. It's just so hard to avoid. It's that specialized language that we all use with each other to be precise that spills over into our work with our patients, and we don't even hear it happening. But the research shows that regardless of education level, regardless of health literacy level, everybody wants the plain language stuff. We were talking about it last night. There's this common notion amongst some healthcare professionals that using big words makes us appear smarter, and that somehow that will convey more confidence to our patients. And that's absolutely wrong, but it's a very common perception. So we need to move away from that misconception. So what do we do when we need a break? We watch TV. So I'm going to show you TV for 1 minute, but this TV show has some jargon in it, and I'm going to ask you to shout out some jargon terms that you hear when we're done, okay? Anybody familiar with Grey's Anatomy? It's a Pacific Northwest thing.
Look, I'll take 10, you take 10. Get in, get out. No smiling, no hugging, no letting no cry. Just be quick about it.
You're the one that's slow.
I am not slow. You are slow.
You want to bet?
Yeah, you are.
A comprehensive workup
Did not reveal any
vascular abnormalities
Your Doppler was negative
for deep venous thrombosis, so there's no need for chronic
coagulation or an IVC pill
Your biopsy was, however, positive
for a mixed anaerobic
non-group-based streptococci infection.
Your BUN and creatinine elevations had us worried,
About rapidly progressive glomerulonephritis.
which could have signaled an autoimmune disease.
What does that mean?
We're not going to amputate your leg.
Huh? You get to keep your kidneys.
Congratulations. You can go home today.
Yeah, congratulations, whatever.
Congratulations. There's nothing wrong with you. You're going to be fine. Congratulations.
Did anybody catch any jargon? Let me hear it. Anticoagulation. BUN creatinine, Doppler. Comprehensive. I like that one. I couldn't hear those other ones. Autoimmune. Negative. What was the other one? Anomaly.
You're gonna be fine.
You're going to be fine. Is that good? Am I all right? Yeah. Oh, I put up some up here that are a little more subtle, and actually some of you mentioned a few of these. Comprehensive. What is that? It's not really a medical word, but in this case, it has a lot of meaning. Rapidly progressive, that's not a medical word. But again, that means a lot here. It might not mean anything to the person who heard it, laying in the hospital bed. Workup, I heard in there. Chronic. This is a big one. When we're talking about adherence to medications and this idea that some things are acute and some things are chronic, and some things you have to take the pill every day for it to work. And on the days when you don't take the pill, things like blood pressure go up. That's kind of an interesting concept. Positive. I just have to take an aside to talk about this term positive. So does everybody know who Rudolph Giuliani is? He used to be the mayor of New York City. So there's this great story about him that great in that it's useful to learn about. It's not great for him. That he was diagnosed with prostate cancer some years ago. And as the story goes, he was in seeing his specialist, a urologist, who is a person who did a biopsy of his prostate gland. And he was sitting down with this person to get the results. And he and his wife sat down, and this urologist said, "The results of your biopsy were positive." And as the story goes, he turned to his wife and he said, "Positive, that's good." Right? Usually. Yeah, of course, in cancer biopsy settings, positive is bad and negative is good. So plain language, what is it? It's living room language. It's everyday language. It's the kind of way that we talk with each other outside of clinical settings. And it's a much easier way for patients to relate to information. It's clear and concise and organized, and it avoids using jargon. Moving on. Best practice number 3, limiting the amount of information we share. So this recommendation goes back decades. So for years we've known that humans can't grapple with a whole lot of new information at one time. That's why standing up here in front of you and showing you a bunch of slides and talking to you for 40 minutes is a terrible way to teach. So I shouldn't expect for you to leave here remembering anything that I say because I've told you too much already. So we should just stop now and just let you take what you've got and we'll be done. But we can't do that. But study after study after study, now back from the 70s on forward, have shown that on average, a patient who is engaged in a healthcare encounter will only remember approximately 50% of what happened during that encounter. It ranges from about 30% to 70%. But in a usual kind of office visit, which I spend most of my clinical time doing, in a 20-minute office visit, the average patient's going to remember 50% of what we talked about immediately afterwards. So the second they leave the building, 50% is gone already. And of the part that they did remember, half of that is misunderstood. All right? 50% of it's gone. Half of that is misunderstood. 25% of the information that I shared with that patient is taken away intact and correctly understood. 25%. But there's no way to know which 25% it is. You don't know if it's the really critical thing that that person needs to know in order to go home and be healthy and safe, or if it's something else that they were tuned into because they were worried about it or whatever. You don't know. There's no way to predict it. So how are you going to deal with that? One strategy is to make sure that you don't provide a lot of superfluous information that could be distracting. Right? So if there's something really critical that you need this person to know by the time they get home, you want them to remember that when they get home, don't add a bunch of other stuff around it, or you risk losing it all. So picking 1 to 3 key critical items and focusing on those. Best practice number 4, eliciting questions. All right, so if you were like me, the way I was trained, I watched all of my professors and instructors end a visit by saying, "Do you have any questions?" Right? That is the professional and ethical way to end a visit. Okay, so we learned that very well. Never left a patient without asking, "Do you have any questions?" Really commonly, though, it's done like this, and you have to. This is a little subtle. You got to watch my face. But you go, "You have any questions?" You understand? All right, great. I'll see you next time. All right? What does the patient say when you say, do you have any questions? Would anybody say, well, actually, yeah, could you mind saying all that stuff again? Never happens, right? So patients always will respond to that by saying, I don't have any questions. I can't think of any questions right now. You've done such a good job. And they leave. And of course, from the slide before this, there's a researcher waiting in the parking lot and says, what do you remember? Right? And they can only remember 50% of it, and 25% or 50% of that is wrong. So they have questions, but they do not feel empowered or comfortable to ask them, right? So this is the simplest thing we can possibly do, is just change the way you say it. You say, whoa, that was a lot of stuff, and this is important, and I'm giving you this new medication. These are really important issues. What questions do you have? It's the same thing, but I've said it in a way that invites a question and that expects a question, right? Now there's no face-saving that has to happen because I'm looking for the question. I'm not saying it in a way that they're going to feel ashamed if they do have a question. All right. And the last one I'll describe here is this teach back, which is really kind of the holy grail of best practices. This is the one that most people have talked about, the one that's been researched the most, the one that is most highly recommended in terms of best practices. And it's like the same thing. If you say, and I watch people do this all the time, do you understand? Do you understand? You got it? Does this make sense? We see this amongst our students and our residents and our faculty as well. Does that make sense? You got a good plan? Great. I'll see you later. Well, you're never going to get an honest answer, right? We know for a fact that people are not understanding. They leave not understanding. They get home. They hope to try to figure it out, but they can't figure it out. So they don't do what you thought they were going to do, and they come back and you label them as non-compliant because they for somehow just willfully didn't want to do what you said, right? So instead, we use this teach back technique. Now, in your professional training, who in here was ever taught to use a teach back? Some people were. Nurse, keep your hand up if you're a nurse. And who put your hand down? Oh. And what jobs were you trained in?
Nutrition, dietetics.
Nutrition, dietetics, awesome.
And pharmacy and sales.
Pharmacy and sales, okay. Marketing.
Music therapy.
Music therapy. All right, so some people are being taught to use teach back. We're finally starting to teach this in our medical schools, but it's been a while. It's been a long time coming, and most schools still are not really doing it very well. And we're trying hard at Oregon Health and Sciences, and we'll see how well we do. We've got a new curriculum that we're working on. Now, so that brings us to the training thing. All right, so that was a sampling of 5 of the best practices. Remember, there's 32 of them that we could be looking at. How do we bring this stuff now into the training environment so that we can get people to actually start doing this stuff when they finish their trainings and go out into the world to be the next generation of healthcare professionals who don't have to come have a conference about it, but who just do this stuff? Well, we start with some competencies. So we can say, what is the knowledge, the skills, and the attitudes that we need to be teaching to our learners? And now this applies to not just to people who are in school, but right, those of us who are out in practice and doing stuff, we have to continue our education, right? So we have continuing education programs. So we could think about this for everybody as well. What are the knowledge, skills, and attitudes that we need to be really effective at working with people with lower health literacy? From a survey that we did of the U.S. medical schools, again, remember, I apologize for harping on the medical side of things, but we did this study amongst medical schools. Only about half of the deans of the schools responded to our survey. We assume that the ones who didn't respond are not teaching anything about health literacy, but we don't know. But of those who responded to us, about 72% said they were teaching about health literacy in the required curriculum. This is great, right? We're teaching, we have health literacy as part of our required curriculum at this medical school. Fantastic. Then we asked, well, how much time are you devoting to it? And the median amount of time spent on it was about 3 hours, right, over a 4-year curriculum. Okay, so that's less time than you've been sitting in these chairs. Okay, so what can we hope to get from that? Well, maybe those schools are producing a little bit of awareness but that's about the best thing we can expect from that level of curricular intervention. This is from that same study, which was asking, well, how do you teach this stuff? What are your techniques for teaching it? For the most part, about 85% or so of these schools were using a didactic format, like we're doing right now, with basically like a lecture, which is the most common way that healthcare professionals are exposed to the topic of health literacies, through lectures. And this is true in other health professions as well, the most common way. And about half of them were using some experiential workshops or things where people were actually practicing and doing things. And we know very well from medical education research that the only way that doctors actually learn how to do things is by practicing things, messing it up, learning how to do it another way, experimenting and practicing, right? So the didactic format has really been shown to be ineffective at producing skills or behavior change amongst physicians and other healthcare professionals, but yet that's really what we're doing for the most part at the current time in terms of teaching about health literacy. From a series of studies that we've done at Oregon Health and Sciences, we know that we can improve short-term knowledge around health literacy, and we know that we can improve planned behaviors, all right? And I think we could show that in this group, too. If we had done it here, you'd show the same results. If I had given you a survey before today, at the beginning of this morning, given you a survey about what you know about health literacy and what your current practices look like, and then gave you that same survey at the end of the day today, I think you would all say that you know a lot more about the knowledge, you have a lot more knowledge about health literacy, and that you plan to go out and use a lot of these best practices. And the things we talked about, the teach back and the plain language and the limiting the amount of information, those things. You would feel energized and you'd feel excited about, I'm going to go out and do this, right? All the studies that have been done have shown great improvements after a training like this. But look at the shape of these graphs. You see a little kind of a sawtooth shape here. I'm going to describe what's happening here. So this is a study we did amongst medical students, first-year medical students. We did a training during the beginning of their first year, a didactic training like this one, basically a lecture. Before the lecture, I gave them a survey about what they knew about health literacy and what kind of best practices they were currently using when they were interacting with patients. And I gave them the same survey afterwards. And as predicted, the knowledge went up and their planned behavior, what they said they were going to go do, really improved. It was like, great. We patted ourselves on the back. We said we did a good job. And then we waited a year, and we got the same group of students back a year later, and we said, okay, now it's been a year, you've been out, you've seen a lot of patients and things, you've done a lot in that time. Now, what is your knowledge base around health literacy, and what are you doing? What are the practices that you're engaged in? And pretty much everything had fallen back to baseline. So this told us that that single didactic format, which most medical schools are using, was not producing any kind of long-term improvements, right? Maybe not surprising, but hadn't really been reported in the literature before, so gave us a place to kind of get a foothold. So here are the conclusions from that study, that the knowledge and the planned behaviors didn't persist. They disappeared over time. And that a didactic model is not going to be an effective way to improve behaviors or the way people practice. So then we did another study, similar, amongst our medical residents. And residents are people who've finished medical school and are now in their supervised training period. So they're doctors, but they have a supervisor who watches over them, sort of. We took these residents, we did the exact same thing. This time, though, I did a series of 4 trainings with them over the course of a year. I had a didactic session where we talked about health literacy, kind of a lecture format. A couple months later, did a much deeper didactic session with them. A couple months after that, we got together and we actually did a skill building workshop where we practiced using plain language and we practiced using a teach-back technique, and they got to do it on each other and develop some skills there. And a few months after that, we did a writing workshop where we learned how to write result letters for our patients to talk about lab results using plain language and low literacy, or low reading skill requirements. So some skill building stuff in there, right? The thought being, well, we won't see that zigzag pattern anymore because we've developed some skills here, hopefully. So this first slide that you're looking at is talking about more knowledge-based stuff, and it's things like I understand what it is to have low health literacy, and I know who's at risk, and I know about a universal precaution stuff like knowledge-based stuff. These residents got the knowledge stuff right off the bat, and that persisted across a year of follow-up. So they really got it. They knew this stuff, and that didn't go away. But when we look at the practices and the skills things, what's circled in the red box here is the use of plain language. And you can't even tell which line it is. It's the top line on the graph, and it has this zigzag pattern to it. What happened was the same thing we saw with the medical students. I'm going to go out and do this stuff. A couple months later, are you doing it? No. Well, let me train you again. Train them again. Okay, I'm going to go out and do this stuff. Come back a couple months later. Are you doing it? No. Right? And we just kept doing that for 4 trainings. 4 trainings in a row. Every time we got back with them, they weren't actually doing what they thought they were going to go out and do. Well, that was disappointing. Here's a few more of them. Asking, what questions do you have instead of do you have any questions? Remember, we talked about that one? Using a teach-back technique. Limiting the amount of information. Each one of these practices, after every training, they felt really good and they were going to go out and do it, and then they weren't doing it. And again and again. So what's going on here? My takeaway from this is that these are really bright medical residents who got the knowledge piece of it, and that stuck. They could get that part. And they got the plan. They were really excited to go out and do these best practices. But something about their work environment, when they got into the clinic and they got into the hospital, the environment did not support the behavior, right? They didn't see faculty role modeling this kind of behavior, and there was nothing in the system to support them, to encourage them, or to incentivize them to do this stuff. So that was really disappointing to me, but I also think if we want to look at the sort of silver lining here is that there's a place where we can do something. If we just build in some incentives into our system, we've got, everyone who's working in healthcare is bright and can do this stuff, just need the right environment to do what they know is right. So I think there's a place where we can make a big difference, is providing those incentives, whatever they may be. Whether it's just saying, hey, we're paying attention, make sure that you use plain language today when you go into those patient rooms. That might be all it takes. That brings us to another study. I wasn't involved in this study, but this one is pretty cool. This was in an internal medicine residency program where they had some videotaped encounters with their residents interacting with real patients. And they had a set of these videoed encounters. Then they did a health literacy training. And then they got some more videoed encounters after the training. And they were able to compare how much plain language was used before and after this training. And they really were able to show that these residents really did a much better job in using plain language, avoiding that jargon after this training. Again, showing that these bright individuals were really capable of doing this when they needed to. What I think was happening here was this bottom line, you see this term Hawthorne effect. It's a research term that refers to the fact that when someone's being watched, they change their behavior. And I think it came down to something as simple as that. These residents knew that their faculty were watching them, so they did what they thought the faculty wanted them to do, which was provide clear communication. That's all it took. So again, I find this very hopeful, and it gives us a place where we can, I think, make big improvements without much effort. All right, I'm going to wrap it up here for us. So, clear communications provides a very promising sort of answer to the health literacy question. We have the best practices. We know what they are. They're well described. We know what to do. We have a problem in that most healthcare professionals don't recognize a need for training in this area, and so they're not going to volunteer to show up for trainings. We have to figure out a way to get them in the door. So there's one challenge for you. We know that training works. It improves awareness, it improves knowledge, and it improves attitudes. And that's pretty consistent across studies. And we know that at least amongst the physicians that have been studied, we can really quickly change the use of jargon. Again, just by saying, hey, I'm listening. Be careful how you communicate. We don't have good studies yet on many of these other best practices, like the teach back. There's no really good studies that say that I can teach this person how to do a teach back and that they're going to go do it yet. But those are coming. And I think if we build the right system supports, we can get all this stuff done really quickly and make some big, big impacts. So communication works. For those who work at it, we've got a lot of work to do, but encouragingly, it might be easier than we think.